Hi, everyone. Thanks so much for being with us. Not sure if y'all were with us last week and this week, so thank you if you're in either of those camps, thanks for being here newly. If not, this week's webinar is going to focus on community perspectives on the Cascade of Care model for medical cannabis. I am going to spend some time to go over what that means in case you weren't here. And for those of you that were here last week, it might be a little bit of a review, but as a teacher and professor, review is never bad. So, okay, here we go. Okay, great. So, in today's webinar, we're going to learn about the Cascade of Care model again. If you, again, either haven't heard about it before or have heard about it just recently last week, you are going to get an opportunity to both hear about some comments that we've received to date, as well as contribute. Loving all the input. We've had some great comments, which is awesome. And you will learn about how you can contribute. I realize I never finished that sentence, but how you can contribute as well. I know there's lots and lots of things we could be doing with our time, so thanks for being with us. So just ask that, you know, your input is really important, so giving us your undivided attention will be super helpful. As I mentioned, we're going to review the Cascade of Care. We're going to talk about comments and input that folks have given us up to now. Our purpose of today is really to focus on the actual discussion and get everyone's input, as opposed to necessarily responding to questions or comments that people might have. So that's really, you know, and to collate this all to really start developing a body of knowledge that we can all share. And if you can share your questions and thoughts in the chat box, that would be great. We have little breaks in between the different phases that'll give us a chance to review them and talk about them as a group. So why a Cascade of Care model now? You know, everyone that's already working in the field has clearly done a lot of incredible work, you know, shoulders upon which that we work upon. But it is, you know, helpful to get organized and bring this evidence-based model to understand resources to a real legitimate medical treatment for patients, to really get it in the eyes of everyone, the legitimacy of medical cannabis. And then really highlighting all the great work that's been done to date. So again, the model here is definitely not meant to discount any of the work that's been done so far. So why me? And, you know, for those of you who haven't, weren't on last week, I'll just give a little bit about who I am. My name is Grace Macalino. I'm an infectious disease epidemiologist by training. So I understand diseases and treatments on a population level. My parents were both doctors. I'm from the Philippines originally, and they wanted me to be a doctor. Unfortunately, in the late 80s, my uncle passed away from AIDS, and this was early on in the epidemic, and it really did sort of change my life in my world for the better. I turned to want to do public health, to impact the idea of being able to impact and give a voice to many, and to those that might not have a voice, and to fight the fight where others couldn't, became really important to me. Over the last 25 years, I've had quite a career that has really spanned anything from working in academia to nonprofit. I worked at the Arthur Ashe Institute for Urban Health, doing health promotion in non-traditional settings like beauty salons and barbershops. I worked on a lot of health disparities issues, really understanding what happens to populations when they don't get good access. And so many similarities to the work that I see is both being done as well as really needed urgently in the medical cannabis space. Most recently, I worked with the Department of Defense, doing HIV and sexually transmitted infection prevention for active duty members, really to protect them while they're busy fighting for us, that we were able to take care of them while, you know, from getting infected. So lots and lots of issues. You know, the field of medical cannabis is really changing quickly. Lots and lots of huge wins in some ways, and, you know, barriers and struggles in others. The impact on recreational comes up a lot, you know. Anyway, lots and lots of issues that, you know, kind of bringing it all together sometimes can be difficult and challenging, especially to someone who isn't familiar in the space. I love this quote from Albert Einstein, where he says, if you can't explain it simply, you don't understand it well enough. And I think given all the efforts of everyone kind of trying to pull the boat forward in the same direction, having an organized framework is super important. So the reasons why we think it's important to have this medical cannabis model is to as I mentioned, organize a framework for resources and collaboration, provide legitimacy and credibility as a clinical healthcare population, and the drug. HIV created a Cascade of Care model in the early, like 2011, and has really almost fostered this consolidated effort to try to get access to those that need it most, both testing as well as treatment. And then it really will help us guide progress and target interventions really where it's needed most. So the medical cannabis cascade of care model that I'm talking about really focuses on 4 different stages. Stage 1 is diagnosis. Stage 2 is linkage to care. So basically getting connected to someone who can prescribe you medical cannabis. Stage 3 is getting receipt of medical cannabis. And then stage 4 is appropriate care maintenance over time. So I'm going to put this question out to the group, and I'll sort of figure out how to look at the chat as well. Basically, do you have specific thoughts on how we've constructed the Cascade of Care model? For those that have given me thoughts ahead of time, one of the issues or comments that had come up was, you know, maybe a better word or phrase to capture phase 1 other than diagnosis. Oftentimes, it's not the diagnosis that's the problem; it's actually restricted, approved medical conditions for medical cannabis. So that was something that had come up specifically. So anyway, just opening it up for thoughts. And if there, you know, if we saw that there are very discrete phases represented by these 4 stages, and just any thoughts on that. So hold on, while you guys are working on comments, let me see if I can add the chat, or let's look at the chat. Okay, I mean, one of the things while we're waiting, if folks have specific comments or not, let's see. Maybe other than diagnosis could be approved conditions, or getting what we really wanted to capture was to make sure that basically if for those that are in states where medical cannabis isn't even approved, they're stuck in that phase 1, right? So you can't even talk or address linkage to care, receipt of drug, or appropriate care if they're not even in a state where access is possible. So there might be a broader phrase or something that we can come up with. I'm not a very good wordsmith from that perspective, so that is definitely something as you're thinking and noodling, you know, with what better word we should use, like, you know, exactly, I see medical condition or demystifying cannabis, and that really, maybe that's a good sort of big picture bucket for like if people don't even know about it as a possibility, or wouldn't even think to ask their provider about it, bring it up. If a provider doesn't know about it, it's sort of stuck in that demystifying cannabis, or maybe that is a good way of describing where folks might get a little stuck in that stage 1 category. So anyway, so that's one of the beauties, or to show you, you know, you develop a model, and it really is only as good as the input you get from folks that are really interacting with the field on a regular basis. Any other thoughts? So I really like some of these ideas. This is great, and we'll definitely continue to play around and let you know what we ultimately come up with. But it really is to capture that big bucket of folks that, you know, really don't even have access to linkage to care. So they're really stuck in this first bucket.
I have lost Grace. So are you guys still there? Can anyone see me? Let's see if we can get her
Debbie,
back.
it seems like you're okay, so let's wait a minute and see if we can get Grace back connected.
Okay. Yeah, she's trying to get back on. Hello. So I do like that, some of your comments too. Medical condition, or might be a good kind of option for that stage 1, demystifying cannabis. I mean, I kind of like that, like, you know, you're just like figuring out that cannabis is an option, maybe is just, you know, figuring out cannabis as an option could be stage 1 too. I mean, a lot of people have had these conditions for a long time. So it's not even really about diagnosis, but it's about kind of realizing when cannabis or that cannabis can be an option.
Yeah, the perception of having that cannabis could be relevant to your condition can be a big realization for a lot of people.
Right. That's actually good, Jeffrey. Yeah, like just realization cannabis. Cannabis can be relevant. Yeah. So she is trying to get back on. Yes, and so generally speaking, people don't always want others to know about their usage, and that's a big hurdle too. And there's many reasons for that as well, you know, depending on where you work or where you live. We encourage people, you know, if they're using it legally, to let people know that they are using cannabis, because we want people to know that this is a real medicine that, you know, anyone, you know, can use. But we want to make sure that you're using it legally and safely in the right way. So that is definitely a hurdle, though. She is having trouble getting back on. Let's give her an, oh. No, you're sideways.
Hello? Can you hear me? Okay, you know what? Desperate times take desperate measures. So I'm calling y'all on my cell phone. No?
Can you turn your cell phone? You're sideways right now. There you go. Right. Perfect.
Is this better? No, wait, hold on. Let's see. You guys see me?
And I thought I was the only one with computer issues.
I know what's happening. Okay. Hi, everyone. I'm so sorry, but listen, we are going to get through this and figure it out. How's that? Okay. Can you guys see me?
Yes, I can.
Okay, perfect. Okay, good. Okay. I can't see anything else though, so let's see. I will. Here, you know what? It's supposed to be a conversation, so it's fine. I'm not even going to. I will read to folks. Okay. Can you see their chat?
Mm-hmm.
Okay, perfect. Okay, so I'm gonna go over. So within the diagnosis, and let me know, you guys, if you think I'm going too fast or too slow. But within diagnosis, issues that folks have brought up from the community, which has been great, is I feel like I need to get involved in politics because they're being very small-minded in my state about what is allowed as medical conditions. The good thing about California, this is another comment that we received, the good thing about California is a doctor gets to decide who can be treated with cannabis or not. You know, a lot of issues came up here where differential approval conditions by state, you know, Florida has a like or kind qualifier. There are 21 conditions in Pennsylvania, and they're super strict about what's included there and not. Another comment someone made is, you know, gosh, it would be great to collate medical professional lists of providers and who understand medical cannabis and really provide support for each other. Work together to get federal laws for medical cannabis, basically just to avoid differences by state altogether and get us all on the same page. And then building alliances between those that are doing work in this area, I thought was a great input, and really almost thinking about building alliances by the different phases I thought was really, really great. So, so those were the comments that I had, at least that we received ahead of time. Hold on, let me see if I can actually look at the comments and chat while I'm on my phone. Hold on. Okay, no, I can't do that. All right. Sorry that I went away. Okay, great.
Do you want me to read? Do you want me to read some to you?
Oh, that'd be great. Just because I think even just right. Thanks.
So, and everyone feel free to, you know, add any more comments, but in this area, there are doctors that will send you home from rehab with your medical card, but other doctors prescribe Suboxone and tell their patients they can't have THC in their system. People are not aware, and the doctors and PA hinder the knowledge. Mm-hmm.
Yeah, I know. And this is great. I think once we start building this, like I said, this sort of composite perspective for folks, I think it can be really powerful. I don't think people realize how many issues sort of, kind of the mountain you need to climb before you actually even get access to medical cannabis, for sure. Okay.
Right, that's true. I mean, yeah. Finding a doctor's that will recommend it is a very, very important step in the process.
Okay, now that's perfect. And then that brings us to stage 2. Okay, sorry we don't have my slides, but we'll send these afterwards to everybody that was on the call for sure, and anyone that wants. Okay, so the stage 2 is called linkage to medical cannabis care. Right, the issues that we had addressed or thought about were few eligible prescribing providers, no standards of care for medical consultation, and barriers to visiting a prescribing provider, anything from fear of going, the cost, no insurance coverage, just really, if we think about, there are already challenges with seeking healthcare in general for everything else, much more added on top of the fact that it's medical cannabis. So someone has to navigate the waters of, already what they're dealing with the healthcare system, much more, cannabis specifically. Stigma and access in rural areas came up for sure. So let's see, hold on, let me get to my slide, which you guys can't see. The biggest difficulty I've had with getting cannabis to some seniors is that they live in facilities that won't allow them to choose their own medicines. So that came up as a comment. Challenge of getting certification to and access to rural areas. One person submitted, our biggest issue would be that doctors use the phrase they're federally funded. I know that came up on the last call. Patients then have to doctor shop instead of using their physicians that they're used to, or maybe have been going to for many, many years. I would imagine even just impacting that balance of the doctor-patient relationship, if a patient is unclear what their clinician or their provider feels about medical cannabis, almost being hesitant to bring it up, right? Another thing that had come up was just really building alliances between those doing work in this area, really understanding where and how. There's so much great work that needs to be done, sort of identifying where and how are there natural sort of opportunities for collaboration. Another issue that came up, comment, excuse me, the need to set standards for qualified specialist physicians. In some instances, there is just the one doctor across the entire region, and while they're good, their interests are limited, and they want to limit treatment options for patients, right? Another person sent in, I provide specifics to patients. I talk about everything with my patients. I'm expected to know everything in my other, when I wear my other hat, yet with cannabis, I'm supposed to pretend I don't know anything. So just really being that advocate to patients for sure. Another person sent in, it's hard for people to go an hour and a half to go see a doctor. Then they have to wait for their card in the mail. So just really almost describing like what that pathway looks like for folks. In some states, it might be a lot easier, and others, it might be harder. What are those steps look like? How much does it cost at every turn, right? And someone else brought up telehealth opportunities for medical cannabis. Like, why isn't that something that's being considered, right? And so, Debbie, I think I'm going to need you, if you're on, just to read, are there other comments or things that just would be helpful for the discussion to bring up?
No one said anything specific, but I think this is a good time to share if people have some other obstacles that they've had that Grace didn't just list, or someone just put they haven't used in the past, so why should they learn it when they are going to retire?
Yeah.
Well, I mean, is that for a doctor or a patient? That's, doctors who don't want to learn about it. Yeah, I mean, that's the problem. Like, it is, as a doctor, it's your responsibility to give your patient options and to do what your patient wants you to do. And so when doctors say, I don't even want to learn about cannabis, I don't believe in it, that's a really irresponsible way. I think, that doctors should at least look into it. Legally, they're not allowed to tell you where to get it. That's pretty much where the legal part ends. They can recommend, they can't prescribe, and they can't tell you where to find it. But they can certainly talk to you about it. So if they say that I can't talk to you about it, that's not true. They can talk to you about cannabis, and they should be educated about it. Right. But yeah, there are a lot of doctors out there that don't even want to look into it. And then at that point you say, well, can you recommend another doctor who might, who would like to talk to me about it? And that should be something that they should do for you.
Yeah. One of the things we're thinking about doing is really, making providers clear that whether they, depending on their stance, whether they choose to prescribe it or not, understanding medical cannabis and how it might potentially, impact other drugs that folks are taking, the prognosis or sort of the pathway of someone's disease is super important. So just understanding, just to reiterate what Debbie's saying, that it doesn't really matter sort of what their perspective is on it. They, being educated about it so that they can contribute to their patients is super important.
Right. And so Teresa brought up a really big point, and this is probably the biggest issue we have right now, is once they have their card, then what? Patients are on their own to figure out what they should use. Success with medical cannabis is often specific, and that is so true.
Correct.
Yeah.
And that actually brings us a perfect segue into our phase 3. But again, I think what's really great is you guys are all bringing up really, really important points and sort of the value of kind of, okay, well, so that just gets us, to they have a card, or they have like, okay, now I'm ready. So what are the issues that now come up with actually getting the receipt of the drug, right? So maybe few licensed facilities and or dispensaries, limited and inconsistent product availability, right? A lack of insurance again, and the prohibitive cost comes up. And then really negative patient experiences, either people have never ever thought to go to a dispensary ever, and this is a brand new thing for them, and what does that all look like? And sorry, I didn't mean to cut you off, Debbie. I was sort of segueing, but sort of to get us to the phase 3, and then opportunities that exist, addressing sort of prior criminal record and how that might impact somebody having access. Lack of civil protections, whether it comes to public housing and child welfare and employment, sort of big issues that will have someone, okay, so now I have this, but, can I make that step to actually go and get to medical cannabis specifically, and how that might differ by, race and gender and age a lot of times. I think that maybe, whatever, maybe younger people might be more comfortable to sort of like, oh, let me, check out this dispensary. But that might be a different, experience for someone who might be older. Some of the community perspectives that we received, and, really rich, it was great. Being able to provide caregiver services to educate folks on medical cannabis, and understanding the broader community of folks that serve people that might actually be, good candidates for medical cannabis. Dispensaries in Florida have delivery services. That might be most helpful since Florida is such a large state, and identifying, kind of creative ways, thinking outside of the box of getting folks access. It would be nice to see a good housekeeping seal of approval for dispensaries as well, and that would allow patients to feel confident in choosing where to purchase their medicine. The importance of educating folks that work in dispensaries. And something that came up is, the folks that work in dispensaries tend to really be focused on recreational use, not medical use. And so, talking about sort of all of their experiences as opposed to how this might help a patient, I think has really impacted folks to maybe not ever go back again, right? So they might have had just a negative experience with going to a dispensary and never go back to not only that one, but wouldn't think to go to another dispensary, kind of almost assuming that it's all the same, right? I feel like maybe changing that culture will be important. The same way that if you don't have a good experience with a doctor, you don't just say, okay, then I'm not going to go to that doctor. You might not go to that doctor, but you might look to go someplace else. But, it might shut down your idea of, kind of cut you off medical cannabis altogether. And then the last comment, building alliances between those doing work in this area also. So just understanding who's doing what, kind of, really getting to learn from what everyone else is doing in this space.
Well, Yeah, and that's a big gap too. I think well, one, I think that one of the biggest gaps is, patients knowing what to buy to go to a dispensary. That's where there's that lack of education. Who's going to tell them what to buy? Who's going to tell them how much dosing? And you really shouldn't rely on a bud tender to do that, to give you that education. Please don't. Please don't. They're legally not supposed to, but it happens all the time. And so patients have to kind of find their own way around trying to figure out what they should be taking and how much they should be taking. But also some of the other comments here were someone wrote, shouldn't all pain management specialists in states where medical cannabis is legal be required to be fully educated on medical cannabis? Wouldn't that be amazing? Easier said than done. I mean, yes is the answer. And also every doctor that recommends cannabis, by the way, isn't required to be educated on medical cannabis. So that's another issue. But it would be great if we lived in a society where this education was seen as important and required. But unfortunately, it's not. And hopefully, we're going to get there one day.
Yeah. Yeah, and Debbie, one of the comments that someone gave, which I loved, I was going to say for later, but I think it was great. It was literally someone who signed into the webinar internationally, actually from Australia, and he was just kind of like, hopefully the United States or us as countries can learn from other, settings and sort of like lessons learned, things that did work, things that didn't, so that we really can, great ideas, right? Really kind of move forward in terms of like, here's something that really, really helped or really worked. So no, I think that's
right. Absolutely. I mean, people think, I just have to say, United States is not doing a great job with this. There are definitely other countries to look to for the way they've kind of gone about medical cannabis programs, but so we do have a lot to learn, and and even the funny thing is states don't even listen to other states. Like, you think that a new state coming in would be like, okay, well, what did this other state do that was great? And that should be what they're doing, and they're not even doing that. So it's kind of interesting. I don't know why people like to reinvent the wheel, as someone once said, but like, I think that, you should look into other states and see what's working and see what's not working. Let's see, what other comments are here? Oh, someone put perhaps phase 4, appropriate care, might be better as phase 3. Ideally, patients would know what they need before arriving at the dispensary. Yeah. Ideally.
Well, and I think, and maybe, yeah, seriously. Well, and I think appropriate care, we might want to change that if that is where people go. Appropriate care is really meant to discuss. So stage 3 is literally getting receipt of drug the very first time, and then appropriate care is sort of maintenance, or sort of what does that look like over time, right? So, stage 4 would include like few evidence-based resources as far as what does treatment and follow-up regimens look like. Few providers are knowledgeable about ongoing care needs. So it's sort of thinking like that. No standards of care for folks at dispensaries, maybe a patient having a negative experience there. So it's almost differentiating it is a milestone to actually get to your dispensary and get medical cannabis the first time. And then what does that look like, kind of getting your drug moving forward?
Right. And someone made a good point in PA about there is no aftercare. We'll see you in a year to renew. And bud tenders are not trained on conditions. And that's why we encourage you to talk to your doctors. And I know a lot of people want to go to just some a business that'll just give you a quick card so you can get cannabis, and that's fine. But if that's our only option, but we do want to encourage you to talk to your doctor. And if your doctor your physician is not into it, then educate them. We have tons of free resources on our website, safeaccessnow.org, that you can hand to your doctor. Cannabis 101. Look how this works. Look how this works about my specific condition. Even we're living in a world where you might be the one that will have to educate your doctor. But it's hard because you do want to be able to talk to your doctor about how this medicine is affecting you, and more than just a year later. And the bud tenders are not trained on the conditions. I mean, that's true as well, as they're not legally supposed to, like I said. But that's not who you should be going to for your medical advice, honestly. And a lot of dispensaries will have medical directors, and so that's, you know, a great option as well.
So Debbie, just to share some of the comments that we received about stage 4, sort of jumping, and I really love that sort of maybe appropriate care is not maybe follow-up care. I saw a kind of chat flash up my screen. I'm trying to learn how to do both at the same time. Patients have to drive an hour and a half to a dispensary, like days and days, you know, kind of waiting and planning. Someone said building alliances between those doing work in this area. So again, that's sort of really important comment. Need for laboratory testing to support consistency of product and understanding of dosage for products. How do we make sure that everything is, you know, consistently appropriate? I know that anecdotally we've heard folks shy away from medical cannabis because, oh wow, it was a lot stronger than I needed or wanted it to be, or, you know, whatever. So I think just understanding, sort of even getting some clarity or standardization in terms of what that looks like would be important. Consensus as an industry around minimum standards. And then here, I've guided our wellness coordinators to ask certain consult questions so that they can help guide patients to the most appropriate choices for them inside of their recommendations. So I guess advocacy and really, you know, all the great work that's being done out there, just knowing that, you know, patients could really use that support for sure.
And someone just wrote here, do a Medscape search. There are a ton of great studies showing various success with cannabis for a variety of medical conditions, including the dosing they use in the study. This will help your doctor understand. That's really great too. I will say though, a lot of doctors are, if it's not a clinical study,
right,
which it's federally illegal to do, so, but they might not think of that as a real study. But I think that's a really great idea. I would still do the same thing. I would like show, like, get as much research as you can, show all these stories, show all these studies that show that this worked. And I do think that's a good idea.
Yeah, and I think, at least from what I've heard, the challenges, even if you had or understood dosaging, I think the product that they might receive might be inconsistent, right? So they have something works for them really well, they go back and that's either no longer there, or they try it again and, you know, they don't have the same effect. So it is a bit of a trial and error kind of, you know, always sort of doing their own sort of one-on-one testing with products that are out there, right? So, so even if those studies were out there and tried to put out dosaging, you know, recommendations, I think that there's still some work to be done as well in terms of, okay, well, what does that even mean when you're in the marketplace, right?
Right. That's a good point, because it could be based on a medicine that's maybe not available where you live, or maybe not available anymore. And that's the problem. And then we also have someone who talked about, you know, definitely like tracking your medicine, your medical treatment plans. Track My Medicine is a great app that you can use to help your doctor. I think that's where we are. We're at this point where I think patients kind of need to, you know, kind of like some other medications, you need to kind of see how it affects you and to adjust your dosing to what your specific needs are.
Still trying to play around to see if I can see these comments.
Oh, you can't see them?
No, not at all.
Okay. Are we still on phase 3? Someone meant phase 4, follow-up care versus appropriate care.
Yeah, I liked that. I saw that.
Right.
Follow-up care as far as, right. I like that, actually. So that actually is a good suggestion.
Right.
Let's see if I can see comments. Okay. All right. No, I think I'd actually gone through appropriate care. Gaps that we had discussed were, you know, lack of patient data and research coordination around use over time. lack of regulatory clarity on new and novel models of administration, such as inhalers, suppositories, kind of like all these new things that are coming out. Like I don't think we understand as much about like how are those dosages being delivered? How does that differ by packaging or dosing kind of thing? There are, as far as opportunities, like identifying how many patients are seen regularly over time by state and how often are they getting treated. I thought that was a really good comment.
Right, for sure, yeah.
And then just a concern around like, and what'll happen once recreational cannabis, comes into my state? Like, how's that going to change the landscape for me as far as medical cannabis? And so that definitely came up here in this sort of follow-up care, I guess might be the better than appropriate care. So once you're sort of receiving medical cannabis, what does that look like once, recreational is now available in my state, right?
Yeah, that is a really huge issue that we at Americans for Safe Access really care about a lot, because our priority is patients. And so we want to make sure that patients' medicine, patients are a priority, first of all. Every state says they're going to put patients as a priority, but does it happen? No. The types of medicine that patients need are very specific, and they need the same kind, and they need a lot of it, and they need it sometimes for the rest of their lives. So I think, making sure there's protections on certain type of medicines available is really important. And, giving patients maybe options for certain days where it's only patients or something like that. I know it sounds crazy, but sometimes patients don't want to go into a dispensary that also is for legalization. It might make them feel uncomfortable. Caregivers, for an examples of children and things like that. So I don't know. There's just different options that states can do to kind of help keep the medical cannabis program robust in a legalized market, because a lot of people think, oh, well, it's legal, anyone can take it now, we're all good. But like I said, we still do want to encourage that patient-doctor communication, and we still see cannabis as a real medicine, and so we want to treat it as a real medicine. We want to make sure if you're taking something for your heart, for instance, and someone suddenly says, sorry, that's not available anymore, right, you should have another option. I mean, so we want to make sure that patients are being taken care of in states that are going, or that are doing.
And Debbie, I love what you're bringing up, because there's a lot of research in other medical conditions that show that does impact whether folks come back and see a doctor on a regular basis or get their drugs on a regular basis. Anything from, if a pharmacy is in a mixed use location where people don't have to sort of be identified or clear that they're not, it doesn't disclose like either what they're taking or, sort of that sort of confidentiality or, kind of concerns for their privacy, right? So if someone who's taking medical cannabis and really doesn't want to feel like, okay, I go to a dispensary, there might be this, whatever perspective or issue, it might actually have them not go anymore or something, right? So I think that's yet another issue that I think needs to get taken consideration, because we can learn from other drugs that are out there and how medicines are delivered to folks, and maybe delivery becomes more of an issue or things like that.
Right, yeah. Well, and then as Teresa said, who lives in Canada, everyone thinks that Canada has this amazing market, but in Canada, when recreational cannabis was legalized, there was shortages for patients. Patients could not get their medicine because it was sold to the recreational market or overseas sales.
Interesting.
Oh, I'm glad to see it has improved a bit, but it is not resolved. But that is our biggest fear. I mean, and I'm sure that's patients' biggest fear, is that that they're suddenly going to have shortages of their medicine, and this is medicine that they need. So, yeah.
Well, and my take-home message is that clearly the conversations for medical cannabis can't go away, despite sort of, if everything were to change and recreational, cannabis was made available in every state, the conversations focused on medical cannabis access, have got to continue. And I'm even hearing loudly that it not only needs to continue, but almost needs to get stepped up even more, right? Because because of this misconception among folks that are cannabis advocates that like, hey, our work is done. It's like, no, it really isn't. Like,
oh my gosh. Yeah, no, yes, not at all. People a lot of the time, and I think I've told this story a few times, but we had a member in California who was like, okay, cool, it's legalized. Thanks. I don't need you guys anymore. And we're just like, what? I mean, great for you. Happy for you. But what about all these other people who still don't have access, who still, have medical needs and their doctors aren't seeing it as real medicine? We still need that education. We still need to, we still need the research. And we still need to think about the whole country, not just your specific county or your specific state. So there is still a lot more to be done.
Well, interestingly, I think even California is also showing us that actually, issues are evolving as time goes on as well, right? So I think that's literally something that, needs to be paid attention to as they start looking at like, okay, well, what do we mean by delivery and what is okay and not okay? And so again, that
exactly. Yeah.
are important to continue for sure.
Oh, and then in New Mexico, a survey about our medical cannabis program by our Department of Health exposed how 55% of our dispensary growers cannot keep up with patient demand. Wow, that is sad for sure. Mm-hmm. And hopefully they're doing something about that there. So yeah, it's patient demand is very important to understand, and the types of medicines that patients need, and
it's funny because that would be, so for example, even getting that data from, across the board, like, is that, not being able to meet demand and understanding. So that's a barrier that clearly just stops folks right there. Right. So, in that phase 3 where access to drug, gets actually stopped. So, something to pay attention to. So just being able to keep up with demand, I think, is something that we need to consider in the model as well.
Yeah. Someone said the main caregiver storefront model should be something other states should consider. There is consistency more that I found in other markets, Vermont and California. Can you expand a little bit on that main caregiver storefront model? Oh, Mark, hi. Yeah, I'm not sure how that model works, but I'd like to know a little bit more about it. If it's something that other states should consider, I would love to send it to other states to consider. So the caregivers can open up a store so it creates competition, lowers prices. Oh, and increases supply. Okay. Okay, that's interesting. Well, so I'm not sure, but I mean, in certain states, if you're a caregiver, you can only have one patient or one person you're looking after. Sometimes you can have unlimited, sometimes you get more. It depends on what state you're living in. I'm guessing in Maine, it's probably more than just one, but so that might not work. It could, in Maine, it could be any patient. PA is 5. Well, that's pretty good.
Interesting. Okay.
Yeah. So I will look into that a little bit more, though, as a suggestion for other states. But yeah. So I can see now that it wouldn't work everywhere, but it is something to look into.
Mm-hmm. But I love that. That does speak to the, what best practices can we learn from different settings across these different phases for sure, right? So
yeah. So
Debbie, another question is, how is your specific perspective in cannabis reflected in the Cannabis of Care model? So if you could see my pretty slides, last week, we basically talked about different stakeholders and kind of like where they're, where they can be focusing their efforts, whether they're educators or researchers and advocates and providers in sort of the different stages, understanding kind of more clearly like, oh, okay, well, dispensaries really and labs sort of kick in at that receipt of drug piece, right? So just sort of putting that out there as a question, do folks have any specific perspectives that they see is reflected in this model?
things that they want to contribute that we haven't, heard yet so far?
Yeah, and I think almost all these comments are really, really helpful and really great, and
Awesome.
expand how we can conceptualize this and think about this.
Perfect.
Someone said physicians in California are not allowed to carry medicine, yet every other medicine can be carried in the office. Why can't something be done about this?
So interesting.
Yeah, that is a great point. I mean, it's so frustrating. But it's because, people don't see cannabis as a medicine. That's the problem. And so until we change that to say cannabis is a real medicine and it should be viewed like any other medicine, then, and in some places, cannabis has to be locked up and stored in a certain container and like hidden and have like a danger mark on it, all this stuff. And then yet the opioids are right next door in an open container. And, it's kind of crazy sometimes the way people think about cannabis. So we're still working on ending the stigma. And until the stigma really, really ends, we're still going to have issues like that.
For sure.
Right. I can carry fentanyl and oxycodone, but they are dangerous and killers, but I can't offer cannabis to my patients. I know. It's so frustrating. So let's see. Oh, thank you. Someone sent an article on the caregiver collective grow model. That's nice.
That's awesome.
Federally schedule shouldn't matter if it's legal in the state. Unfortunately, it still does actually matter if it's federally illegal, because there are just federal law oversees all state laws, and so until it is rescheduled, we really are going to still have a lot of issues with where you can take cannabis and how you can and where you can use it and things like that. So yeah, people should understand. People should always know their state laws, but also federal law, because you do want to know what is federally legal and what isn't.
So I just want to share some current initiatives that we definitely know are moving forward, to follow up, I guess, from all of these great insights. Debbie and I are definitely going to go back and take all your comments and modify and edit the Cascade of Care model as we sort of initially conceived it. It's been really, really great to get this input. We are looking to develop the Merrimack Insight Research Institute with a Cannabis Center of Excellence, really to focus on this setting research standards and guidelines across the field, gathering all cannabis research across multiple states, and really working with and collaborating with anyone that wants to partner to start identifying where and how we can address some of these issues across the board. In partnership with ASA, we're focusing on a Cannabis of Care survey that we're going to be putting out in the short term, really starting to ask the way research works. A lot of what we've done the last few calls is really qualitative research to basically, very loosely kind of collect information from key stakeholders to identify, what are the important issues to be sure of, make sure get collected, and then in a survey, be able to sort of get more in-depth and quantify, how often is this happening? For example, demand coming up, how often is that happening to you or in your state? And sort of understanding those issues, I think, will be super, super helpful. And sort of please be on the lookout for that. As it develops, we'll be putting that out there and looking to, get links to patients and folks that can help us answer important questions like that. We're looking to develop patient experience benchmarks and data collection best practices that are aligned with the Cascade of Care, and then really developing a repository of data. Partnering with both those that have data as well as developing standard data collection processes. Really, I know a lot of people are doing great research out there, but really looking across all the work that's being done to really help, focus on access, really understanding how a lot of the great work that's being done impacts access. And then I guess sort of our like kind of big picture questions, sort of like, from your perspective, where do you see is the greatest need or gap in the knowledge or access within the cascade of care? There's lots and lots of, we've identified, even from the beginning of the series, no new news. There's a lot of work to be done for sure. But, it'd be interesting to sort of hear your thoughts in terms of, what do you see as gosh, we just need to hit this issue first and foremost to, open up access for the greatest number of people. So, not like we're going to answer questions here today necessarily, but the idea of, would love to hear your thoughts. If you were going to focus attention on any one specific area of the cascade of care, what do you think is the biggest one to address? Well, I'm hoping that the beeping sound means that people are making comments.
Well, I think what's important to mention as well is that this model that we're talking about can really be, it could be, for a specific condition. Yeah. It could be used for a specific condition. It could be used for a specific state. It could be used for a specific population. Yep. So if you think about like the whole world, it kind of like, it can be overwhelming. But if you put it into a specific condition or a specific population, and what is this specific population's needs or, lack of access, it kind of helps it. And so that's what we're looking at doing as well, as kind of looking at specific conditions or populations or areas where we can take this model and then use it to see what the lack of access is for something more specific. So
yeah, no, very much so. Yeah, it really does help. And it's funny, we were sort of playing the game of like overlaying different, if you kind of take the whole world of medical cannabis, it can get quite messy. In this framework is helpful, but then you can almost imagine like, okay, so here's the PTSD, group experience, and sort of maybe the biggest gap for that group might be in actual, a lot of them are military and they're concerned about going to a dispensary, like whatever, sort of focusing on the specific issues that are unique to that particular population, as opposed to, I don't know, whatever, chronic pain where they've already feel like they've, been kind of turned away at a good number of turns for a number of reasons, and they're just hesitant to even seek out one more thing or something, right? I just made that up, but, just kind of looking at how some of these issues might be unique to specific populations for sure. Okay, I'm still trying to figure out where to see the chat, but
oh, you still okay? We're just talking right now. People are just talking about federal law and state law and how it can, how it kind of interacts with each other. So,
yeah, I mean, one of the biggest take-home messages, at least from the policy perspective, was, really having that concerted effort to move medical cannabis laws to the federal level for sure. If we can kind of remove this individual states,
right,
reinventing the wheel and different, understanding the flavor of the month in this setting kind of thing, it could really help make a lot of the work that great people are doing locally, be able to sort of impact folks across the board. So I think, if anything, as always, Asa, you're sort of championing that effort and that discussion, at least at the last Unity conference, was really important in terms of, really focusing, kind of pulling that, all in the same direction.
Right. And for those who don't know, we at ASA, we have created like a federal legislation on medical cannabis that we're trying to push. It's basically an oversee of medical cannabis at the federal level. And so, because I mean, something that we didn't also mention during this webinar was just like, people that do have access to medicine, you can't leave your state. You can't visit family on holidays. You're committing a crime if you take your medicine over state line, which is crazy, right? And especially when you live in an area, let's say like DC, Maryland, Virginia, where we're constantly driving over state lines. It's just, we know that is a huge problem. And so, you know, we're trying to look for solutions. Yeah, reciprocity between states is a big thing. A tri-state area, PA, West Virginia, Ohio, all within 10 miles, right?
Oh,
I don't know if it was, I know someone told me recently that in order to get home from where they work, they have to drive into another state. And so, yeah, it was you. Okay, yeah, I remember that. And it was, and so that's a problem. If you need to take your medicine, you know, you literally every day are committing crime by driving across another state, which is, yeah, it's just, it's crazy. So we need to look for solutions at a federal level in order to help that. So, well, we're at 2:58 right now, so I think
yes, we are coming to the hour. But thank you so much for your input, your thoughts. Actually, I think one person might have emailed me right before the webinar. So if you weren't on, I will definitely be sure to make sure that those comments are included. Please send us more thoughts and comments. You know, we will keep you posted about our future work in this area, but we really appreciated your input and your thoughts today for sure.
And we're going to post this webinar on our YouTube channel, and which is also can be found on our ASA webpage. So I'm just going to send that right here in the chat right here. You can find our last webinar if you didn't get a chance to see that on there. And then in a few days, maybe tomorrow, we'll have this one posted there as well. And we'll also send you all a link as well, since we have your email addresses when it's posted.
Yeah, no, for sure. And definitely we'll send out an email kind of with an updated Cascade of Care model based on some of the great input that we received today, for sure. That was the purpose of today. And thank you. It's super, super helpful. It was great.
Thank you all.
Okay, great. Have a great afternoon. Bye, everyone.
Bye.